Hello and welcome all. Today's topic is how can we optimize extubations in our ICUs? Extubation failure, defined as the inability to sustain spontaneous breathing after removal of the artificial airway and need for reintubation within 24 to 72 hours or up to 7 days, is associated with high morbidity and mortality, as well as long-term disability. The incidence of extubation failure in intensive care units remains quite high in the literature, between 10% within 48 hours and 15% within 7 days. Two main causes of extubation failure can be identified. First is weaning failure, the patient's unreadiness to breathe without respiratory assistance, or second airway failure, the patient's unreadiness to breathe without an artificial airway. So how to optimize the patient? Make sure the reason for intubation has resolved. Without this, proceeding with extubation trial is dangerous. Second that needs to be done is a SBT or spontaneous breathing trial. It should preferably be done with PSV or pressure support ventilation, though TPs can be used in patients who are longer on ventilator support. During SBT, lung USG can be done to check for atelectasis. Similarly, cardiac function can also be evaluated during this period. Extubation on vasopressors is controversial. A recent study that suggested that extubation on low-dose vasopressors, that is less than 0.1 micrograms per kilogram per minute, could be safe and associated with a lower mortality and a shorter ICU length of stay. Patient on low-dose supports can be extubated without problem. However, those on high dosages should wait until further improvement. Assess coughing of the patient. If the patient can bring the secretions into the tube, then it's considered a good cough. Next is amount of secretion. If the frequency or quantity of secretion is more than extubation may be deferred. Check if fluid balance is negative. If not negative, consider fluid depletion, that is use diuretics and or do dialysis. Evaluate the risk of stridor following extubation in high-risk patients, like prolonged intubation, cuff leak test. Steroids may be given in these cases. Check and optimize electrolytes before extubation, especially potassium, magnesium, phosphate. What can we do after extubation to optimize the patient? Use NIV and or HFNO following extubation in high-risk patients, like obesity, COPD, heart failure, CKD. An effective clearing of the airways requires a balance between production and removal of respiratory secretions that can be reduced by respiratory muscle weakness and upper airway dysfunction. In this setting, physiotherapy through cough augmentation techniques seems of great importance following extubation. So to summarize, check cause of intubation has improved. Respiratory function, during SBT. Cardiac function evaluation. Cough power. Secretions. Electrolytes optimization. Post-extubation. Use NIV, HFNO and physiotherapy. These steps may help in reducing reintubation. Thank you.